Hi, everyone. Welcome to Anatomic Pathology Friday. Thank you for joining, whether you're in person or on Zoom. Today, we have two of our second-year students presenting case studies that they worked on, Aaron Ramos and Avery Sims. First up, Aaron.
Hello. The title of my presentation is Diagnostic Challenge, Metastatic Pulmonary Adenocarcinoma presenting as an Adrenal Cortical Carcinoma. And I'll go over a few learning objectives before we get started. By the end of this presentation, participants will be able to differentiate between primary adrenocortical carcinoma and adrenal metastases based on clinical radiologic and histopathologic features, understand the importance of hormonal assays in the workup of adrenal masses, appreciate the importance of multidisciplinary collaboration, primarily in radiology, pathology, endocrinology, and oncology in the diagnosis and management of adrenal masses, understand the diagnostic role of immunohistochemical markers in identifying the primary origin of adrenal masses, and recognize the adrenal gland as a common site of metastasis in pulmonary adenocarcinoma and its implications for staging and management. And prior to getting into case-specific details, we'll go over some relevant information. The adrenal glands are also known as suprarenal glands and are retroperitoneal, triangular-shaped endocrine glands superior to the kidneys within the perinephric fat and covered by Gerotis, or encapsulated by Gerotis fascia. The right is described as being pyramidal in shape. The left is more crescentic. Each consists of two distinct tissue layers, an encapsulated outer cortex with a high fat content, giving a distinguishable yellow hue. The inner medulla is described as being reddish brown. Veins and lymphatics leave at the hilum, and arteries and nerves enter at various sites. And normal organ size and weight is 4 to 6 grams and 3 to 5 centimeters in greatest dimension. The adrenal glands have a multilayered cortex covered by a connective tissue capsule consisting of type 1 collagen. Each layer of the cortex secretes a specific class of steroid hormone, and going from superficial to deep, first we have the zona glomerulosa, which produces mineralocorticoids, primarily aldosterone, which plays an important role in electrolyte balance and blood pressure regulation. The middle layer is called the zona fasciculata, which produces corticosteroids, primarily cortisol, which regulates the blood sugar via gluconeogenesis in the liver, and also can raise the blood sugar with insulin sensitivity. It helps also taper the immune system by acting as an anti-inflammatory agent and regulates metabolism of fat and proteins. The innermost layer of the cortex is known as the zona reticularis, which produces sex hormones, primarily androgens, which play a role in secondary sexual characteristics, which are physical traits in males and females that are unrelated to sexual reproduction. The inner medulla is derived from ectodermal neurocrystals called chromaffin cells, which are neuroendocrine cells which produce catecholamines, which combine with amino acids such as tyrosine to produce other stress hormones such as dopamine. Adrenal masses are often discovered by chance and are referred to as so-called incidentalomas, and are essentially adrenal masses that are discovered on imaging that is done for a non-related issue that's non-related to adrenal disease. This is an example of a flow chart in the management of adrenal incidentalomas. So for instance, a patient will come in for a CT or MRI, they discover an incidental mass in the adrenal glands, and the first thing that they're gonna do is do a biochemical workup to determine the functionality of the masses. In functional tumors, we have, in adrenal functional tumors, we may have a pheochromocytoma or aldosterone producing cortical tumors related to Cushing's disease, which would produce cortisol, and ACCs, which are adrenocortical carcinomas, which may be mixed or produce either one of the aldosterone or cortisol producing tumors. And on the other side, we have non-functioning tumors, which are usually discovered incidentally on imaging. And a differential diagnosis for non-functional tumors would be an ACC or a metastasis, or just a non-functioning malignant process. And these, the an adrenalectomy is often preferred due to the fact that there is a small chance of tumor cell dissemination on biopsy, and it's it's based on size for non-functioning tumors. The breast and lung cancer are the most common primary cancers metastasizing to the adrenal glands, and common metastatic sites of adrenal primaries include liver, lung, and peritoneum. And to go over a little bit of adrenocortical carcinoma, which I'll refer to as ACC from this point further, just because it's a mouthful. ACC is a particularly rare adrenal mass that often occurs sporadically, but it can account for up to 14% of incidental adrenal masses. 50% are said to be functional hormone-producing masses. The other 50% are non-functional and are typically larger just because they may be present within the patient for longer periods of time before discovery. There are some hereditary cancer syndromes that are related to the development of ACCs, such as Lee-Fraumeni syndrome, which accounts for most pediatric cases, and up to 3% of patients with Lynch syndrome can present with an ACC. Insulin-like growth factor 2 is proposed as the main oncogene involved in the carcinogenesis of ACC. The median age at diagnosis is 55 years, with most patients being female and Caucasian. 50% of patients with ACC have a 5-year survival rate, and factors affecting prognosis include tumor stage, metastatic spread, patient age, tumor characteristics, and the functionality of the mass itself. Functional ACCs further can be categorized by what type of hormone they secrete. Up to 50% are cortisol secreting hormones, 20% are sex hormone secreting, 8% are aldosterone secreting tumors related to Conn syndrome, and 15 to 25 may be mixed hormone secreting. And this is important because patients can undergo what's called an Addisonian crisis, for instance, in cortisol producing tumors, which is characterized by an acute drop in adrenal hormones. Non-functional ACCs present primarily in two ways. 80% create what's called a local mass effect, which may include GI issues, organ compression or back pain, or even mimic an infectious process, such as with localized pain or fever due to cytokine release from highly necrotic tumors, which often ACCs have a large necrotic aspect to the tumor itself. 90% are sporadic with no established risk factors other than smoking, and 5 to 10% are related to those previously mentioned hereditary cancer syndromes. What to expect in the gross room: you would expect a solitary, bulky, and yellow, tan, or red mass, usually greater than 200 grams. The cut surface would be described as heterogeneous with areas of necrosis and hemorrhage. Tumor size is between 10 to 12 centimeters. And unfortunately, the larger cases tend to be pediatric cases, and the largest reported is apparently 28 centimeters. And this is an example of a diagnostic workup that you might use in determining the true nature of the mass. So with you would consider clinical presentation, imaging, hormonal workup to determine functionality, and biopsy, even though adrenalectomy is definitely preferred. And now to present the specific case details. In this case, we had a Caucasian female in her early 60s with a 45-year smoking, 45-pack-year history of smoking. She also had a history of stroke and aneurysm, and a reported familial history of lung cancer, unspecified in her mother and father. They did perform a CT of the abdomen, which revealed bilateral adrenal masses. In the left was a greater than 6 centimeter mass, with the surgeon mentioning radiologic characteristics of an adenoma, which is a benign tumor rising from the cortex, but can also be functional and non-functional. On the right side, there was a 2 centimeter mass. And so they performed a CT of the chest, which revealed a 1.2 centimeter nodule in the superior segment of the right lung lower lobe with some lymphadenopathy. And so a right transbronchial biopsy with endobronchial ultrasound was performed. It was a 7-part biopsy, which returned negative for malignant cells. They did find infarcted lung parenchyma with fibrosis and adjacent atypical epithelium, and some acute and chronic inflammatory infiltrate was present. She did report a recent infection with a recent pneumonia infection, cultures were taken and are negative to date. And she had also complaints of left-sided abdominal and flank pain. And as far as APA grossing guidelines in accordance with CAP, this is an example. On the left is an example block summary that you could use to generate or to when considering which sections to submit when receiving one of these in the lab. But just in general, you want to just a few pointers: orient and ink, especially if the specimen is intact. Measure in 3 dimensions, sample of the vasculature, section in 2 to 3 millimeter intervals. You want to measure the tumor in 3 dimensions and specify the location, whether if arising from the cortex or the medulla. Describe the cut surface, the color and consistency, and the presence of hemorrhage and/or necrosis, and the degree of circumscription or encapsulation. And as with all parenchymal organs, you want to include the weight, especially because the weight is heavily correlated with benign or malignant processes. And also describe the uninvolved cut surface if possible. And definitely include the thickness of the cortex, because some glucocorticoid secreting adrenal cortex tumors will have some atrophy in the cortex itself, which can help the pathologist in their diagnosis. This is a dictation that I created for this case, and I highlighted the main points. So basically, we received an intact, unoriented left adrenalectomy with a scan amount of attached yellow adipose tissue that weighed a total of 66 grams, and the specimen itself weighed measured 8 by 6 by 3 cm. There was one stapled vascular margin that I was able to sample. Upon cutting, it revealed a Yaltan mass with a solid Yaltan heterogeneous cut surface with some grossly necrotic areas, and it was involving pretty much the entire medulla. So as far as the mass, I took a 3D measurement and measured 7 by 4 by 2 cm. The cortex was also thickened and fibrotic, measuring up to 0.4 centimeters. And I submitted a total of 7 blocks in this case. These are case photos that I took myself, and I also included the picture from pathology outlines that I had provided earlier. And you can see that there's some striking resemblance between a true ACC and the adrenal gland that we received in the lab. And obviously the proof is in the pudding, and histology will reveal the true nature of the mass. So to discuss what we actually received. In the diagnosis of ACC, the WISE scoring criteria is used, which lists 9 histologic features of an ACC, or rather an adrenocortical tumor of unspecified type. The presence of 3 or more of these would constitute a malignant process and would keep ACC in the differential diagnosis. So but some essential features that we might expect to see include severe nuclear atypia, a high mitotic count, possible vascular invasion, tumor necrosis, and cells that stain with an eosinophilic cytoplasm. What we saw in our sections were cells there was some nuclear pleomorphism, a very high mitotic rate, which would constitute this mass as a high-grade tumor, poorly differentiated cell clusters in a necrotic background. Some of these cells themselves had a very high nuclear to cytoplasmic ratio. And rather than being more eosinophilic, they were more amphiphilic, which means they were taking up both acidic and basic dyes. And we didn't identify any lymphovascular invasion. So I think at this point, and this is a lower power magnification histomicrograph of the mass that we had. The top image, the bottom image is another sample of ACC from pathology outlines. So I think at this power magnification, you can appreciate the acinar glandular growth pattern, which is indicative of a possible adenocarcinoma and a probable metastasis. And also just to correlate that with the clinical features, we had the right adrenal mass. So in ACCs, bilateral involvement is rather uncommon. In less than 1% of cases, it will present this way. And the top image just displays malignant cell clusters arranged arranging themselves into round or oval glands. Let me see. You can actually appreciate like some of the empty luminal spaces here and just the general shape of the cells themselves. So I think at this point, the pathologist that signed this case, I was thinking this is probably an adenocarcinoma, which correlates with the fact that there were bilateral adrenal masses, which is most likely. And it did have a glandular growth pattern, even though some mixed tumors may present with squamous or small cell morphology, and most commonly from the lung. And so at this point, I think considering the pleomorphism in the cells themselves, we could rule out a benign adenoma, but we still are left with primary adrenal malignancy, most likely ACC, or a metastasis, especially from lung or breast. And so at this stage, we can rely on additional diagnostic tools to assist us. So we did perform some immunohistochemistry, which is a diagnostic technique employing immunostains, which can be used to identify and locate specific proteins within their proper histological context. And just upfront to go over some of the negative stains that we, or some of the stains that we performed that actually turned out negative. This is an example of a stain differential from pathology outlines that you would expect to see in an ACC. So in ACC, we're looking for stain positivity and stereogenic factor 1, calretinin, inhibin, MART1, and synaptophysin. For ACC, we should have negative stains for PAX8, GATA3, and CK20 that we performed, which does check out these stains were negative. PAX8 was used to rule out a kidney or endometrioid process, GATA3 to rule out breast and bladder primaries, CK20 to rule out colon primaries, MART1 was to rule out a melanoma, and P40 is to differentiate between squamous and adeno. And so one stain that should have been positive for ACC was MART1, but it did stain negative. So there's already some conflicting negative results that we received in the context of ACC. But we did have 3 stains that stained positive that were allowed us to characterize this tumor. So synaptophysin should stain positive for ACC, and in fact did stain positive. It's an integral membrane glycoprotein, which would give a cytoplasmic staining, and is generally positive in neuroendocrine tumors and adrenocortical tumors as well. But as mentioned, you would expect to see this negative in lung adeno, even though there have been reported cases of synaptophysin staining positive in lung adeno that are from neuroendocrine differentiation. But most likely what we're seeing here are normal chromaffin cells that are incarcerated within the tumor itself that are staining positive for synaptophysin. And we also did have weekly staining positive stains for inhibin and calretinin. The next stain that resulted in a positive results was a CK7, which is a type 2 keratin, which would give a cytoplasmic and membranous stain. It's generally expressed in adenocarcinoma of the lung, generally negative in adrenocortical tumors, and lung in general are typically CK7 positive and CK20 negative, which definitely correlates with our negative CK20 that we discussed earlier. This next stain is basically the one that gave it away as a lung adeno primary. We had a positive stain for TTF1, which is thyroid transcription factor 1, which is a binding protein expressed in thyroid, lung, and brain. And it gives an exclusive nuclear stain. And the thing with TTF1 is that there's 2 monoclonal antibody variants that are highly specific for lung adeno, which are 2 of the most commonly used. And you can see here that the stain is extremely positive and even highlights even more the glandular differentiation with these empty luminal spaces. So I think at this point, the pathologist was comfortable with his diagnosis as a lung adeno versus an adrenocortical primary. We did have positive margins in this case, which is a negative prognostic factor because it indicates that not all of the tumor was removed and increases the likelihood of residual disease to the area. And most likely this patient will require some systemic or radiotherapy. And I do believe this patient was referred to oncology for further management. And just to go over the AJCC staging, had this mass been a adrenal primary, it would have been listed as a T3 for the positive margins and local invasion. And the final diagnosis was given, taking into consideration the clinical histologic and IHC findings as a poorly differentiated metastatic lung adenocarcinoma. And I think this case overall highlights the diagnostic complexity of adrenal masses in general and emphasizes the need for a systemic approach involving imaging, hormonal studies, and histopathologic evaluation. And to go over some lung pathology, pulmonary adenocarcinoma is the most common non-small cell lung carcinoma, and adeno suggests arising from glandular tissue. Carcinoma suggests epithelial origin. Metastasize, common metastatic sites are only often to the brain, but can include bone, liver, and adrenal glands. The mechanism of metastasis remains unknown, but the risk for metastasis increases with tumor size. Smoking is the greatest risk factor, but other risk factors include cooking oil fumes, radon, exposure to radon in soil, and asbestos. It does prefer male to female between the ages of 60 to 70 in the upper lobe and periphery rather than central. And 5 main histologic types include acinar, papillary, micropapillary, lipidic, and solid. And these tumors do stain positive for TTF1, and CK7, and are CK20 negative. And to include AJCC for the lung, this is definitely a T4 tumor of the lung, and considering the metastatic site to both adrenal glands, this would affect the PM category because of multiple extrathoracic metastases in a single or multiple organ. And just to include a discussion slide for why this case posed a diagnostic challenge, pulmonary adenocarcinoma rarely presents initially with adrenal involvement. Brain is often the only metastatic site. Therefore, it could be said that it was mimicking a primary adrenal tumor, especially because the CT revealed such a small mass in the lung. The symptoms and imaging findings of ACC and adrenal metastases can be similar. Imaging characteristics of adrenal masses may not clearly differentiate ACC from metastases or even a benign process. As mentioned before, the surgeon made a comment about the CT showing characteristics of an adenoma of the adrenal gland. Adrenal masses can be hormonally active or inactive in both ACC, metastatic disease, or even in a benign mass, making hormonal results potentially misleading. Biopsies overall may be smaller necrotic, and they often prefer adrenalectomy anyway, so we might not even receive biopsies prior to receiving the actual excision. IHC markers may show overlapping expression, which was true in this case if we think about the IHC results in the context of an ACC. But if we think about our IHC results in the context of a lung adeno, everything did check out. And also the delayed identification of the primary site, and the primary site may be small in general, which was true in this case. We had a 1.2 centimeter nodule, which came back negative for malignancy in a 7-part biopsy. But the pathologist that signed that case out did mention that they could not rule out that the biopsies were taken from the edge of a neoplasm. And that pretty much concludes my case. And I'd like to give a special thanks to Dr. Chris Giampapa, who signed this case out, and Dr. Ashley Porter, who signed the previous biopsy case out, as well as Jonathan Sukdeo, PGY3 at Regional 1, who went over this case with me. This is a picture of the hospital where I was rotating at when I received this case. And these are a list of my references. You know what? I don't think they removed the lung primary yet. As far as the last that I could read in some of the op notes was that the patient was referred to oncology. So I think they're going to do some chemo, radio, and I don't know, maybe try to shrink the mass and then do a lung resection. Because we didn't receive the right side either, which was interesting. Any other questions? Thank you very much.
Thank you, Aaron. Well done. Our last presentation is given by Avery.
Hi, everyone. Thank you all for joining today. My name is Avery Sims. I am a second-year pathologist assistant student here at UTHSC. And over the first half of the summer, I was rotating at University of Tennessee in Knoxville, where I got to gross a variety of cases. And today I will be presenting on one of those cases, benign squamous cell carcinoma, an uncommon yet aggressive malignancy. So here are the learning objectives for my presentation. By the end of my presentation, you will be able to recall the gross and microscopic anatomy of the penis, recognize common penile pathologies, both benign and malignant, explain the clinical features and pathogenesis of penile squamous cell carcinoma, apply the AJCC staging system and cap grossing protocol when evaluating penectomy specimens, distinguish between well-differentiated from poorly differentiated squamous cell carcinoma, and finally evaluate the impact of psychosocial factors on delayed diagnosis of penile lesions. So here is the outline of my presentation. I'll first go over the anatomy and the microanatomy of the penis. I'll then move on to the most common pathologies we see occurring in the penis. Then I'll go into the AJCC staging guidelines and the cap grossing protocol applying to penectomy specimens. And then finally, I will talk about the case study and then give a final diagnosis and discussion at the end. So moving on to the anatomy and microanatomy of the penis. The penis anatomy can be broken down into three major segments: the base, the shaft, and the glans. The penis is covered by skin. We know this as keratinized stratified squamous epithelium, although I will note in an uncircumcised penis, the glans is covered by non-keratinized epithelium. It's considered mucosa. However, once the penis becomes circumcised, that skin becomes hardened and keratinized. Now, the coronal sulcus is an important landmark we see on the penis. This is a groove where the base of the glans meets the shaft, and this is pathologically significant, as I will discuss a little bit later. Within the penis, we see three cylinders of spongy, highly vascular tissue called corpora. At the dorsal-most aspect of the penis, we see these two cylinders called the corpus cavernosum. These are highly vascular and they're considered the erectile bodies of the penis. And then on the ventral aspect of the penis, we see the corpus spongiosum, and this is the cylinder that surrounds the penile urethra, which is the final third segment of the male urethra. And finally, the corpora are surrounded by connective tissue known as Buck's fascia. So if we were to take a cross-section of the penis, this is what we would see under the microscope. We have the paired corpus cavernosum here, as well as the penile, the corpus spongiosum surrounding the penile urethra. And now taking a closer look into the corpus cavernosum, it is highly vascular, like I mentioned, so we see large arteries as well as these vascular sinuses that allow the tissue to fill and then drain with blood. And then the architecture of the tissue is built up of tuberculae, which is made up of smooth muscle cells and loose connective tissue. Now taking a look at the corpus spongiosum, it's a little similar where it has the same tuberculae with the smooth muscle cells and the loose connective tissue, but this tissue is a little bit more dense and isn't as vascular as the corpus cavernosum. And we instead see the penile urethra, which is lined with pseudostratified columnar epithelium, as well as periurethral glands, which we also see surrounding the female urethra, which secrete mucus to help lubricate the urethra. As for the skin of the penis, it looks pretty similar to skin you'd see in other areas of the body. We see this most superficial layer, the stratum corneum, which is a layer of dead keratinized cells. The majority of the epidermis is made up of the stratum spinosum. And then finally, the most deep layer, we see the stratum basale, which is where the cells are actively replicating within the penis. And like I mentioned, in an uncircumcised penis, the glands won't have this keratinized layer at the top. And now moving on to the most common pathologies of the penis. So I've broken this down into benign, borderline, and malignant disorders. Benign disorders can be further broken out into infectious and inflammatory types. Infectious benign disorders are almost always transmitted sexually. We commonly see condyloma acuminatum, which are these benign wart-like growths that are associated with low-risk HPV types, types 6 and 11. So they don't have the potential to become malignant, but they are highly recurrent. Herpes simplex virus is the most common cause of genital ulcers on the penis. And then syphilis, we see a little less common today in modern day, but there are 3 different stages to this condition with different pathologies and morphologies to each. As for inflammatory disorders, phimosis is a condition that happens in uncircumcised penises where we see the foreskin failing to properly retract, and this of course causes inflammation of the glands. Lichen sclerosis is a skin condition that can occur anywhere on the body, but we see it commonly occurring in the genital region. It's chronic inflammation that causes these plaque-like growths on the skin, which almost resemble lichen on a tree. Peyronie disease is a condition where we see benign fibrous thickening of the dermis and the buccal fascia, preventing proper erection. And then squamous hyperplasia is a condition where we see a growth of the cells, the epidermal cells, without any atypia. As for borderline disorders, bonoid papulosis is similar to condyloma acuminatum, where it produces wart-like growths. However, this condition is caused by high-risk HPV types, types 16 and 18, so it does have the potential to become malignant. Penile intraepithelial neoplasia, also known as carcinoma in situ, is a precursor to squamous cell carcinoma. This is when we start to see neoplastic cells that are confined to the epidermis. However, they have not yet breached that basement membrane, so they're not considered malignant just yet. And now moving on to malignant disorders, squamous cell carcinoma, which I'll be discussing further today. This can be HPV associated or HPV independent. Adenosquamous carcinoma is similar to squamous cell, however, we start to see glandular differentiation within the cells. This is a little bit more rare, as well as basal cell carcinoma. This is also quite rare on the penis because it usually is associated with UV exposure. And then finally, urethral carcinoma is a carcinoma of the epithelium that lines the urethra. Now diving into squamous cell carcinoma of the penis a little bit more specifically. It is the most common penile neoplasm. Although it's quite rare in the United States, it represents less than 1% of carcinomas in men. However, and you can imagine that this is even a smaller number of cancers overall. It most commonly occurs between the ages of 50 and 70, with a median age of 68. It has a higher incidence in less developed countries, likely due to that lack of health care and lack of health literacy overall. It almost exclusively happens in uncircumcised men or men that have undergone a late circumcision, such as after the age of 10, whereas circumcised men have a 70% reduced risk. And this is because we see a lot of these cancers associated with the foreskin or the glands. And the risk factors for SCC of the penis include phimosis, which I discussed, poor genital hygiene, long foreskin, genital warts, which increases the risk for about 6 times, penile injury, smoking, and obesity. HPV-related squamous cell carcinoma occurs in about 45 to 80% of cases, and it's usually caused by those high-risk types that I mentioned, type 16 or 18. Whereas HPV-independent squamous cell carcinoma can take on various different forms. The usual form is ulcerated, which we'll see today, as well as verrucous, papillary, and sarcomatoid. Now talking a little bit about squamous cell carcinoma in general, it is a malignant tumor of the squamous epithelial cells. It is the second most common type of cancer overall, right behind basal cell carcinoma. It can occur anywhere on the skin, but it's most likely to occur on those sun-exposed areas. But we also know that this can occur in the mucosal linings within the body, such as the esophagus or the lungs. Risk factors, UV radiation, of course, as well as chronic ulcers, chronic inflammation, burn scars, HPV, and chronic immunosuppression. Now, this condition is typically treated by surgical excision, and most patients thankfully have a favorable outcome because this condition usually grows quite slowly. However, we will see that this is not the case for today. This is the progression of squamous cell carcinoma. We first start to see dysplasia. This is characterized as disorganized cell growth. With low-grade dysplasia, we see this typically occurring within the basal layer, usually about one cell layer thick, whereas high-grade is considered multiple layers of the epithelium, possibly full thickness. However, it's considered carcinoma in situ when those cell growth becomes irregular and those cells become neoplastic. But they have not yet breached that basement membrane. However, once they do breach that basement membrane, they have access to lymphatics and blood vessels, and it is now considered invasive squamous cell carcinoma. So squamous cell carcinoma can take on various different appearances. Thin and early stage lesions usually look like a scaly patch or papule. They might look a little erythematous like we see in this nodule here. And thicker and later stage lesions tend to crust over or ulcerate like we see in this bottom image. And typically patients go to their dermatologist or their doctor complaining of a patch or a sore that fails to heal. That's characteristic of this lesion. Now taking a look into the microscopic view of squamous cell carcinoma, it can vary from well differentiated to poorly differentiated. Differentiated meaning that the tumor resembles the cell type that it arises in. So with well differentiated squamous cell carcinoma, we see keratinization. We see these keratin pearls forming. We also see intracellular bridging. This is a little hard to see in this image here, but that's those desmosomes that are seen between the cells. And overall, it just has more pattern and uniformity within it. Whereas with poorly differentiated squamous cell carcinoma, we don't see those characteristics such as the keratin pearls or the intracellular bridging. And instead, we see lots of nuclear pleomorphism as well as just variety between cell shapes and sizes. Now moving on to the AJCC staging and cap grossing protocol when evaluating penectomy specimens. So as for AJCC staging of penectomy specimens, they are staged based on the structures that the tumor invades. So as for PTIS, this is considered carcinoma in situ, which I pointed out. It's when the tumor is confined to the epidermis. PT1 can be further broken down into the glands, the foreskin, and the shaft. Glands is when it invades the lamina propria. Foreskin is when it invades the dermis, the lamina propria, or the fascia. And a shaft is considered when it invades the connective tissue between the epidermis and corpora, regardless of its location. Now, PT1 can be further broken down into A and B. A is when the tumor is without any lymphovascular or perineural invasion and it is not considered high grade, whereas PT1B is when the tumor exhibits that lymphovascular or perineural invasion or is considered high grade, and it is considered grade 3 or sarcomatoid. PT2 is when the tumor invades the corpus spongiosum, that ventral-most cylinder that surrounds the penile urethra. PT3 is when the tumor invades the corpus cavernosum, that dorsal-most cylinder, the highly vascular tissue that I pointed out earlier. And PT4 is similar to other types of cancers when it starts to invade into adjacent structures such as the scrotum, the prostate, or the pubic bone. Now, when I was reviewing the cap grossing guidelines, here were some of the key takeaways that I found. When evaluating foreskin specimens just on their own, sectioning of that coronal sulcus margin is especially important because that's where we'll see a lot of these squamous cell carcinomas arising from. Carcinomas of the foreskin usually have a better prognosis and are more easily to treat, whereas carcinomas of the glands tend to be higher grade and usually associated with HPV. The most common appearance of penile squamous cell carcinoma is an ulcerative non-exophytic mass. However, we can see rarely verrucous and papillary forms. Tumors that invade the corpus cavernosum are at a high risk for metastasis compared to those that only invade the corpus spongiosum. This is likely because of how vascular this tissue is. And wide dissemination can occur at late stages. Now, the heart actually is an interesting, very a common site for metastasis, as well as the liver and the lungs. But the most clinically significant factors overall when it comes to penectomy specimens is that involvement of the corpora, the percentage of the tumor that is considered poorly differentiated, the size of the largest lymph node metastasis, any extranodal extension, and the HPV status of the patient. So now moving on to our case study. So the case that I received at my bench was from a male in his mid-60s. He underwent a circumcision or penile surgery for an abnormal ulcer seen back in March and also had a catheter placed as well. I will note that this happened at a separate facility, so we don't have a lot of information on what was going on, but all we know is that cancer was found in that tissue removed and further surgery was suggested at that time. However, the patient did not get surgery right away and instead presented to the ER in June for an open wound, pain, and drainage at that surgical site and around the catheter. The emergency department labs found mild leukocytosis, as well as urinalysis that was suggestive of a UTI. And they performed a CT scan, which found a prominent right inguinal lymph node that looked a little suspicious, as well as possible cystitis and possible esophagitis. So that we know that there was some kind of inflammatory reaction happening in the body. As for the clinical history, the patient had been diagnosed with coronary artery disease, atrial fibrillation, hypertension, lower extremity edema, and had a spinal surgery in the past. He was currently on antibiotics for that E. coli that was found in his urine. There was no known family history of cancer, and his HPV status was also unknown. He denied smoking, drug or alcohol use, and we also do not know his sexual history. But at that time, he was admitted to the ER, and the doctors assessed the state of the penis, and they decided that a penectomy was the best course of treatment. So here's the specimen I received at my gross bench. I took pictures of the dorsal view, the ventral view, the base margin, and the distal tip. And you can see here at the distal tip, there was this pretty big ulcer that was taking up pretty much the entire glands, which I noted. And I also examined the base margin. We see here that it's pretty regular. Now I will note that this wasn't the true margin. They ended up submitting an additional margin. So this isn't the true margin, but we do see the two corpora cavernosum here, as well as the corpus spongiosum, and they stitched the urethra. So as for my gross description, this is kind of a breakdown of what I mentioned. I first gave the overall dimensions of the specimen. I noted that the surface of the specimen was remarkable for this ulcerated site that seemed to take up the entirety of the glands. I gave that depth of the ulcer, and I described that the specimen was circumcised and there was a scant rim of skin surrounding the glands. As for the base resection margin, I mentioned that it was irregular and it contained a non-propatent urethra. Now, as for the cut surface, I decided to cut down longitudinally down the urethra, and that's when I found a pretty ill-defined white tan cut surface, and I called this possible tumor because I wasn't quite sure what I was looking at, but it seemed to involve the entirety of the glands, the areas of the corpora cavernosa, areas of the corpus spongiosum, and it seemed to come pretty close to that urethral margin. It spanned about 6 centimeters in greatest dimension. So here was that cut surface with that pretty ill-defined white, yellow, tan area, taking up pretty much the whole glands, as well as invading into the more proximal segment of the specimen. Now we do see a little bit of this pale pink here. This was what was left of the corpus cavernosum. But you do see here that the pale cut surface was pretty much abutting that inked margin, which I noted. So this is what the specimen looked like under the microscope. You can see my base margin here, which I inked black, the urethra here. And when I consulted with the pathologist, he mentioned that this entire cell layer was all neoplastic cells. So it was going all the way up into that base margin. Now taking a higher power view of those neoplastic cells, we did see areas of moderately differentiated cells that looked a little bit more epithelial-like, and there's a little bit more organization among them. But most of the specimen consisted of these poorly differentiated cells. And taking a closer look at these poorly differentiated cells, they don't look very epithelial. They instead look very spindle-like, almost like what we would see in a sarcoma. And this is what the pathologist called sarcomatoid cells. And like I mentioned with the AJCC staging, sectioning of that corpora tissue is especially important for staging. So I was sure to include sections of that. Now this is the area, that pale pink area, that where there is still viable corpus cavernosum with the trabeculae, the vascular sinuses. And then here we see that tumor invading into the corpus cavernosum. We no longer see those trabeculae or those vascular sinuses, so we know that the tumor was automatically upstaged to a PT3. Now moving on to the final diagnosis and a brief discussion. So the penectomy specimen ultimately was diagnosed with invasive squamous cell carcinoma. It was considered moderately to poorly differentiated with areas of sarcomatoid differentiation, which I pointed out. As for the extent, we know that the tumor invaded the corpora cavernosum, so this was given a PT3 stage. There was no angiolymphatic or perineural invasion identified. And as for that base margin, the tumor was abutting that margin, but however, I did mention that that was not the true margin. And thankfully, in that additional base margin that they sent, this was negative for malignancy, and they only found mild chronic inflammation in it. Now, interesting enough, if you can remember when I mentioned the CT scan, that the patient had an enlarged lymph node. And so I was surprised they did not take any lymph nodes for this case. I'm not sure if they possibly were able to perform more tests and rule out any lymph node metastasis. And for a brief discussion, like this case, many patients with penile cancer usually delay seeking medical attention, up to 50% of patients. And this is often due to embarrassment, fear, social stigma, and just the overall sensitive nature of the topic. One doctor even noted that it's common for patients not to present for up to a year with something that's been going on with the penis. And of course, we know that this delays treatment and is linked to larger tumors, less opportunity for penile preserving treatment, and worse functional outcomes overall. Now, penile cancer is rarely discussed, but I do think there are some ways that could help this delay in presentation, such as just public awareness, stigma reduction, improving health literacy, and just encouraging earlier biopsies. Now, one thing I did want to add is that reconstruction surgeries have grown vastly in the last decade, and this phallic reconstruction is available for patients, which is where they take vascularized tissue from the forearm or the thigh and pair that with a penile implant, which I thought was interesting. All right, thank you all for paying attention today for me. I want to acknowledge Dr. Alan Grindstaff, who was the pathologist on this case, as well as Taylor Busby, who was the PA who assisted me in this case. Here are my references. Are there any questions? All right, thank you.
Well done, Avery. Thank you. And thanks for everyone for your attention and for coming today. Hopefully we'll see you Friday, September 26th for Forensic Friday. Thank you and have a great Friday.